Sethi, please.
Thank you, sir. Good evening, everyone. I'll be discussing surgical management of the third nerve palsy. So third cranial nerve supplies all the extraocular muscles except the lateral rectus and the superior oblique. It also supplies the levator palpebrae superioris, the sphincter pupillae, and the ciliary muscle. The lesion in this case can be at any level, nuclear, fascicular, or orbital, and all of these cases will present differently. There may be the palsy may be partial or complete, and there may be associated neurological deficits. So the clinical picture may be highly variable. There can be varying degrees of exotropia, hypotropia, hypertropia, and ptosis. There may be aberrant regeneration and varying degrees of contracture of the recti. So it is important to establish a complete ocular motor diagnosis, and we need to examine, look for deficits of the fourth cranial nerve, the sixth cranial nerve, and the fifth cranial nerve. Investigate for the cause of palsy, and allow 6 to 9 months for natural recovery of the patient, natural recovery of the palsy before planning a surgical correction. So what are our options for surgical management? We can perform a recess resect procedure. We can perform medial transposition of the lateral rectus. We can perform periosteal fixation procedures like the lateral rectus periosteal fixation or the medial globe anchor. So to establish a surgical plan, we need to pay attention to certain aspects, like what is the kind of deviation in primary position, what are the limitations of movement, what is the severity of limitation. It is always important to perform a force duction test to identify the contracture of any of the recti muscles. And if there is contracture, it is important to establish if there is any residual function in the involved muscle, and also if there is any aberrant regeneration. So coming to the first case, this is a case of right eye partial third nerve palsy. There is a 40 prism diopters of exotropia in primary position, but the patient is able to adduct the eye up to the midline. So in this case, we can get away with a supramaximal recess resect procedure in the right eye, and we can achieve a good alignment. So what if the patient is not able to adduct the eye up to the midline or beyond the midline? In this case, if the lateral rectus is free, we can perform a lateral rectus to medial rectus transposition, and one of its variants is the full width lateral rectus to medial rectus transposition. In this, it is indicated especially in those cases where there is associated vertical deviation as well. It can correct up to 50 to 60 prism diopters of exotropia when combined with the posterior fixation suture. So here is a case of right eye post-traumatic third nerve palsy with exotropia and hypertropia. So in this case, we chose to perform a full width lateral rectus to medial rectus transposition via the inferior route to correct the hypertropia. Here is a similar case of right eye third nerve palsy with associated hypotropia, and in this case the full width lateral rectus to medial rectus procedure was performed via superior route. So we can also perform the medial transposition of split lateral rectus muscle. In this case, a Y split is performed on the lateral rectus, and the two slips are transposed to the insertion of the medial rectus. This was described by Gokigate et al., and in the original paper they were able to achieve a correction of 55 to 60 prism diopters of exotropia, but it was prone to undercorrection. So Saxena et al., Professor Saxena augmented it with a posterior fixation suture, and a correction of 75 to 80 prism diopters could be achieved. So here is a case of left eye congenital third nerve palsy with a free lateral where the FDT for adduction is free. In this case, we can perform a split lateral rectus to medial rectus transposition with a posterior fixation suture, and we can achieve a satisfactory outcome. So all these procedures were fixed procedures, and to make them adjustable, Shah et al. Inserted the slips of the lateral rectus on adjustable sutures, and this provided the option of adjustability in the post-op period. they inserted the slips of the muscle on the same vertical side of the medial rectus, and it made the procedure adjustable, but in cases of undercorrection, there was not much opportunity for advancement of the muscle. So it was augmented by inserting the lateral rectus in a crossed manner, such that the inferior slip of the muscle was inserted at the superior border of the medial rectus and vice versa. Then this enhanced the exotropia correction, as well as provided more room for advancement of the slips of the muscle in cases of undercorrection. So this is a case of exotropia due to third nerve palsy, in which enhanced adjustable nasal transposition of split lateral rectus muscle was performed. In this case, we had an undercorrection of 14 prism diopters in the post-op period, and both the slips of the lateral rectus were advanced to achieve a final outcome of 6 prism diopters of exotropia. So this procedure provides adjustability for the vertical deviation as well, in which case we can advance or recess individual slips to align the vertical, to correct the vertical deviation. So what if the lateral rectus is tight and we are not able to transpose it to the medial side? In these cases, if we attempt a transposition procedure, it can lead to avulsion of the muscle, or sometimes even if we are able to transpose it, it can compress the vortex veins and cause a choroidal effusion in the post-op period. So in these cases, it is important to perform a periosteal fixation of the lateral rectus. This frees the globe for adduction. So here is a case of right eye complete third nerve palsy, in which a lateral rectus periosteal fixation was performed with a medial rectus resection of 8 millimeters, and good alignment was achieved in the post-op period. But if there is no force in the medial rectus, resection will not be able to help. So in this case of right eye complete third nerve palsy, a lateral rectus periosteal fixation was done along with a medial rectus resection. But due to no force in the medial rectus, we had a residual exotropia in the post-op period. So in these cases, we can fix the globe to the medial orbital wall, and we come to the next procedure, that is the anchoring of the globe to the medial orbital wall. So in this case of left eye complete third nerve palsy, the lateral rectus was tight, and there was no force in the medial rectus as is seen on AFGT. So in this case, we performed a medial globe anchor along with the lateral rectus recession of 12 millimeters. So we can see that we have achieved good alignment in the primary position, but it is important to tell the patient that the eye almost becomes still and it will not have any movement at all after the surgery. So here is another case of right eye congenital third nerve palsy, which was corrected with a lateral rectus recession of 12 millimeters with the medial wall periosteal anchor, and with the crutch classes, the alignment is achieved. Coming to the cases of aberrant regeneration may follow acute traumatic or compressive third nerve palsies. So here is a case of left eye third nerve palsy with exotropia and hypotropia. We can see that as the left eye adducts, the ptosis improves. So we see that there is a medial rectus to LPS aberrant regeneration. In these cases, we can plan a supramaximal recess resect procedure in the other eye. The supramaximal lateral rectus recession of the other eye increases the innervation to the medial rectus of the involved eye, and this in turn increases the innervation to the levator palpebrae superioris, and the ptosis improves. Here is another case of left eye congenital third nerve palsy with aberrant regeneration. In this case as well, we see that as the eye adducts, the ptosis improves, and in this case we can utilize this to correct the ptosis. So in this case, we performed a right eye lateral rectus resection of 15 millimeters with medial rectus resection of 8 millimeters, and we achieved a beautiful outcome. Coming to the last section, targeted strabismus surgery. This is indicated for congenital cranial dysenervational disorders, including the involving the oculomotor nerve, that is the synergistic innervational downshoot and the synergistic divergence. So synergistic divergence, in this case we can see that synergistic divergence is seen in both eyes. As the patient attempts a dextro gaze, we can see that the left lateral rectus cross-sectional thickness is increasing, that is, it is indicating that it is contracting. And in attempted levo gaze, we can see that the right lateral rectus and inferior rectus are contracting. So the patient is having a downshoot in attempted levo gaze. So in this case, in these cases, the principle is to identify the misinnervation and to transpose the misdirected muscle to the correct site. So a periosteal anchor of the lateral rectus was performed in both the eyes, along with the right eye inferior rectus to medial rectus transposition with the posterior fixation suture. And we can see that in post-op period, the innervational downshoot has reduced quite a bit, and also exotropia has reduced. So to summarize, in the cases of third nerve palsies, it is important to identify the kind of deviation that we are planning to correct. If there is good adduction, consider a recess resect procedure. If the adduction is poor and FDT is free, we can plan a transposition procedure. And if there is poor MR action and FDT is tight, we can plan periosteal procedures. So thank you. What I have not discussed is individual medial rectus palsies, IO palsies, and in those cases a tailored approach is needed. Thank you.
Thank you, Dr. Anin. And I'll now call upon Dr. Rebecca from RP Center to speak upon 6 nerve palsy. And while you set up, Dr. Rohit, you could tell us a little bit about trochlear palsy.
There's a question. Yes, please.
Sir, all these procedures look so heroic, but how do we counsel the patient for the double vision they'll have even post-op? Because most of these procedures also cause restriction of movements.
So in all these procedures, if the patient has binocular vision, there is the risk of post-op diplopia. Although if you've brought the deviation to fairly close to each other, if the alignment is fairly good and there is very small angle in primary position, they are not going to have a diplopia in primary position, which is what we can offer them. Usually they would maintain a small head posture and be able to be functionally positive, and whenever they look on the side, usually the movement is so much more that the image again starts getting ignored, like they were ignoring in the early period. But yes, it's a problem that you have to inform the patient about. And over time, usually patients do. In the early post-op, they may feel uncomfortable, and I've had a couple of patients tell me actually that, you've made me worse than before, and reverse it. But usually a little later, they're usually happy and comfortable, and that's, yes, John, I think one...
role of adjustables in them, sir?
So some of them, you can do adjustables, like we've talked about the LR to MR as an adjustable procedure. If you are going to do any resection, suppose you do periosteal fixation of the lateral rectus, the medial rectus resections can be adjustable. But there is modest, because many of these surgeries, as you said, fairly severe. So the scope of adjustment is only a very small amount that you can possibly manage. Yes, John, and then we'll go on to the next talk.
Yeah, just a short comment. We have the same problem with our patients after the third surgery, and they will, if we're lucky, they will not have double in primary, but they will have double everywhere else. So we give them a occlusive contact lens in the palsy eye, and then they look normal, but they will only use one eye.
So yeah, that's a good one. Okay, Rebecca. So we go on to the